Hi everyone, this is Dr. Shanmugapriya, a prep ladder faculty for Biochemistry. This is the Biochemistry part of FMGE 2023 Flashback series. For this session, I've chosen high-yield MCQs in the latest 5-year question papers of FMGE. I will not only be discussing those MCQs, I'll also be telling you about relevant or related facts and concepts. Because as far as FMGE is concerned, when we say repeat questions, they are not direct repeats. They repeat topics, and based on those topics, related MCQs are often asked. So whenever you work out previous year questions, try to learn related facts and concepts as well, and that is the background of this session. So if you stay with me for the next 2 hours, my assurance to you is you will be 100% confident in facing any biochemistry MCQ in the upcoming FMG exam. Okay, so the first MCQ for today is a 25-year-old male. This was an FMG June 2021 MCQ following COVID-19 pandemic, and the question was, a 25-year-old male returning from China was found to have fever. What is a specific diagnostic test that needs to be performed? So even before NEET PG or INI-CET paper started having COVID-19 based MCQs, we saw this MCQ in FMG. That tells you the magnitude of transition FMG papers have undergone. So please remember, you will have to know all must-know facts and concepts related to every subject. So what is a specific diagnostic test for SARS-CoV-2 or any viral infection which you suspect following transport or travel to China? It is real-time PCR or reverse transcriptase PCR, right? So the answer is choice D. Now what does RT-PCR stand for? RT-PCR here is reverse transcriptase PCR, because SARS-CoV-2 virus is an RNA virus. So before you can perform any amplification technique, you have to convert those RNAs to DNAs, for which reverse transcription is done. After that, quantification, amplification is done by real-time PCR. So please remember, RT-PCR for all practical purposes would mean reverse transcriptase PCR, that is followed by quantification by real-time PCR. And don't fall for answers like ELISA. ELISA can be done to detect antigens or antibodies. So antigen detection test sensitivity is always low. And if it's antibody detection test, that there is always a window period between the time a person gets exposed to an infection and antibodies start developing in a person. And to avoid such a longer window period and to make it more sensitive and specific, it is always reverse transcriptase PCR or real-time PCR, which is used for infectious disease diagnosis. So answer is choice D. This is the next question. A person has a history of alcoholism for 20 years. This is an FMG December 2021 question. Can you see that most of these MCQs are clinical case based these days? Okay, so my advice to you is, don't get worried whenever you see a case based MCQ. For a case based MCQ, just follow 2 steps. Step number 1 is read the stem of the question, summarize the clinical features. Step number 2, start excluding choices. Yeah, that way you'll be able to narrow down to at least 2 choices from 4. Okay, so I'm going to help you solve this. So history of alcoholism for 20 years, has avoided alcohol for 2 days, and has presented with agitation, global confusion, disorientation, hallucination, fever, high blood pressure, diaphoresis, and autonomic hyperactivity. So you see both the mental and physical manifestations here. The most common causes. Can we exclude choice D straight away? Yeah. So pancreatitis is not going to present with hallucination, fever, high blood pressure, or autonomic hyperactivity. The person would not present with global confusion or agitation or disorientation. So we can straight away exclude pancreatitis. And because there is a history of alcohol withdrawal for 2 days, what is going to be a diagnosis? It is delirium tremens. It is one of the features of alcohol withdrawal. But before we start discussing about delirium tremens, let me tell you how to exclude choice B and choice C, because many students ended up choosing it as choice B just because they saw this term global confusion. And what is Wernicke's encephalopathy? All of you please remember, Wernicke's encephalopathy is one of the features of alcoholism, and this is acute thiamine deficiency. Okay, acute thiamine deficiency presents as Wernicke's encephalopathy, and manifestations of Wernicke's encephalopathy can be remembered using a mnemonic GOVA. What does GOA stand for? Global confusion, ophthalmoplegia and ataxia. So this term can be misleading. This is a common feature of both Wernicke's encephalopathy and delirium tremens. But why have you excluded Wernicke's encephalopathy here? This Wernicke's encephalopathy does not present with physical manifestations or autonomic hyperactivity. Okay, and the clinical manifestations here does not include ophthalmoplegia, does not include ataxia. So I am going to exclude Wernicke's encephalopathy. Now what is Korsakoff syndrome? That is chronic thiamine deficiency, and this presents with amnesia. Do you understand the difference between Wernicke's encephalopathy and Korsakoff syndrome? Of course, Wernicke's is acute and Korsakoff is chronic. But apart from that, manifestation wise, in Wernicke's encephalopathy, there is just a confusion. But in chronic thiamine deficiency, there is complete memory loss. You observe retrograde amnesia, anterograde amnesia, and whenever there is memory failure, to fill up the gaps, they start fabricating stories. And that is what we call as confabulation. And there is also sensory agnosia. So tell me, what are the features of Korsakoff syndrome? Retrograde amnesia, anterograde amnesia, confabulation or fabricating stories. We also call this as a white lie. Okay. For example, you're looking at a patient who's suffering from Korsakoff syndrome, and you're pointing out and asking who this is. You're pointing out the person's son or daughter and asking who this is. The person would say, this is my sister's son or my sister's daughter, not because the person wants to evade responsibility, but because the person looks familiar, but the person is not able to find out who that is actually. Okay, so they fabricate stories saying that this is my sister's daughter or my brother's daughter. So that's called as confabulation or fabricating stories. So we have excluded Wernicke's encephalopathy. This is not Korsakoff syndrome. What is the answer? It is delirium tremens. So few words about delirium tremens. It's one of the features of alcohol withdrawal, and it's most commonly observed between 3rd and the 10th day of withdrawal. And it presents with GHN. The mnemonic that you can use to remember the manifestations of delirium tremens would be GHN, Government Hospital Nurse. G stands for global confusion, H stands for hallucination, N stands for nightmares. And apart from this, they also present with physical manifestations. Physical in the sense they present with fever. They present with high blood pressure, high heart rate, tremors, that is why the name tremens. All these because of autonomic hyperactivity. Okay, so what is the right answer here? The right answer here is delirium tremens, because there is a history of alcohol withdrawal and you see features both physical and mental. This is an interesting MCQ. It's FMGE June 2021 MCQ. The neutral lipid which is stored in liver is, yeah, they're asking you what is responsible for fatty liver changes. Accumulation of which neutral lipid will cause fatty liver changes? The answer is triacylglycerol, because triacylglycerol is a neutral lipid, whereas every other choice that is provided here are amphipathic lipids. So based on solubility, you can classify lipids into two types. One is amphipathic lipid, the other one is neutral or non-polar lipids. On what basis do we classify them this way? Lipids are non-polar. Okay, whenever you're asked to define lipid, you can close your eye and say it's going to be non-polar. Okay, so when I say lipids are non-polar, then depending upon whether there is an additional polar group or not, you can classify lipids. If a non-polar lipid has got an additional polar group, you will call it as an amphipathic lipid. If a non-polar lipid does not have any additional polar group, you will call it as a non-polar or a neutral lipid. This is the basis of classification. Now I'm going to tell you the names of various lipids. You're going to tell me where to place them. Okay, let's start with cholesterol. Is cholesterol amphipathic or is it neutral? The name tells you everything. Cholesterol has got OH. OL means it has got OH. OH is a polar group. A lipid has got an additional polar group, which means it is amphipathic. So cholesterol is an amphipathic lipid. How about cholesterol ester? How can you convert cholesterol into cholesterol ester? When the hydroxyl group here gets attached to a fatty acid, what you get is cholesterol ester. So in cholesterol ester, there is no polar group that is free. So what kind of lipid is this cholesterol ester? Cholesterol ester is a neutral lipid or a non-polar lipid. Okay. Where will you place phospholipids? Phosphate group is negatively charged. Anything which is charged is polar. So a non-polar lipid has got an additional polar group. So phospholipid is an amphipathic lipid. Where will you place triacyl glycerol? In triacyl glycerol, you start from glycerol. Glycerol has got 3 OH groups. Only when all these 3 OH groups get attached to 3 fatty acids, what you get is triacyl glycerol. So in triacyl glycerol, none of these polar groups is free. Triacyl glycerol is completely neutral or a non-polar lipid. So triacyl glycerol comes into this category. So can you all tell me what are the amphipathic lipids and what are the neutral or non-polar lipids? If you're watching this video, try to type the answer in the chat box below. Amphipathic lipids would include cholesterol and phospholipids. Neutral lipids include cholesterol ester and triacyl glycerol. And this understanding is essential for you to understand lipoprotein structure, and that is why this is being asked. And because the question is, the neutral lipid which is stored in liver is, your answer is going to be triacyl glycerol. The next question, and this is one MCQ which was marked wrong by most of the FMG aspirants. Okay, the MCQ is a very interesting clinical case based MCQ. A 2-month-old boy presented with ambiguous genitalia. His blood pressure was normal. The dihydroxytestosterone value was also low. The probable diagnosis is. So can we follow step number 1? What is step number 1? I told you, summarize all positive features. So what are the positive features here? A boy presenting with ambiguous genitalia is nothing but male pseudohermaphroditism. So the first feature is male pseudohermaphroditism. Second feature is normal blood pressure. Okay, and if you look at all these choices, these are all causes of congenital adrenal hyperplasias. So I was thrilled, I was thrilled to see that congenital adrenal hyperplasia based MCQs are asked in FMG. Okay, so if you look at congenital adrenal hyperplasia, please take this from me. Most of the congenital adrenal hyperplasias present as female pseudohermaphroditism. Can you memorize this? Most of the congenital adrenal hyperplasias present as female pseudohermaphroditism. The only one congenital adrenal hyperplasia which presents as male pseudohermaphroditism is 17-alpha hydroxylase deficiency. So what is the right answer here? The right answer here is choice C. And I know that most of you chose choice A, which is 21-beta hydroxylase deficiency, just because you have come across this term often. So which is the most common congenital adrenal hyperplasia? The most common congenital adrenal hyperplasia is caused by 21-beta hydroxylase deficiency, but that presents as female pseudohermaphroditism and as salt wasting forms. What do I mean by salt wasting forms? No sodium reabsorption. So there is hyponatremia and hypotension. They often present with hypotension. So do you see that both these features are just opposite here? You don't see hypotension. There is no female pseudohermaphroditism. There is male pseudohermaphroditism. So this is definitely not 21-beta hydroxylase deficiency. It is 17-alpha hydroxylase deficiency. So as far as congenital adrenal hyperplasias are concerned, I am going to tell you just 4 facts. Okay, so please memorize all those 4 facts, in which case you will be able to answer most of the MCQs based on this topic. Okay, so the first fact is the most common congenital adrenal hyperplasia is caused by what? It is caused by the defect of 21-beta hydroxylase enzyme. Okay, that is point number 1. Point number 2 is they most commonly present as female pseudohermaphroditism. So which is the only congenital adrenal hyperplasia which presents as male pseudohermaphroditism? That is 17-alpha hydroxylase deficiency. Point number 3. Most of the congenital adrenal hyperplasias present as salt wasting forms. What do I mean by salt wasting forms? They present with hyponatremia and hypotension. So what are the examples? Examples will be the most common 21 beta hydroxylase deficiency and 3 beta hydroxysteroid dehydrogenase deficiency. So what are the salt wasting forms? 21 beta hydroxylase deficiency and 3 beta hydroxysteroid dehydrogenase deficiency. How do we remember this? 2 get wasted to become 1. Right? 2 get wasted to become 1. That's how I remember it. So salt wasting forms include 21 beta hydroxylase deficiency and 3 beta hydroxysteroid dehydrogenase deficiency. Whereas there are some adrenal hyperplasias which present as hypertensive forms. So what are the hypertensive forms of congenital adrenal hyperplasia? 17 alpha hydroxylase deficiency and 11 beta hydroxylase deficiency. So 17 alpha hydroxylase deficiency and 11 beta hydroxylase deficiency will present as hypertensive forms. So if you remember these 4 facts, most of the case-based MCQs on congenital adrenal hyperplasias can be answered. Okay. So what is the right answer here? The right answer here is 17 alpha hydroxylase deficiency. A 25-year-old male, another case-based MCQ asked in June 2021. A 25-year-old male presents with hypercholesterolemia. So the first finding is hypercholesterolemia. His elder brother also died of a heart disease a few years back. So there is something just congenitally happening. An LDL receptor defect was observed. So they given you the answer already. Yeah, what have they given you? LDL receptor defect was observed. So what is the most probable cause? LDL receptor defect is called as familial hypercholesterolemia. Is it not logical? Just think logically. If LDL receptor is defective, LDL will not be cleared off from the circulation. So LDL stays back in the circulation. LDL carries cholesterol. So blood cholesterol level increases. So what will you call that condition is familial hypercholesterolemia. Okay. Now what is A beta lipoproteinemia? This is not going to present as hypercholesterolemia. This is not going to present as heart disease. A beta lipoproteinemia is being frequently asked in competitive and clearance exams. Please remember this. This is caused by the defect of microsomal triglyceride transport protein. Yeah, it is caused by the defect of this is caused by the defect of microsomal triglyceride transport protein, and because of this both chylomicron and VLDL cannot be synthesized. Okay, that is why it's called as A beta lipoproteinemia, because chylomicron comes with ApoB48 and VLDL comes with ApoB100. When the triglyceride transfer protein does not work, triglyceride does not get loaded to both ApoB48 and to ApoB100. So the levels of both ApoB48 and ApoB100 will be low. That is why it is called as A beta lipoproteinemia. And because chylomicron is related to fat absorption, what will it present as? A beta lipoproteinemia will present as fat malabsorption or steatorrhea. And only when fat gets absorbed, along with that vitamin A, D, E, K, all fat soluble vitamins get absorbed. So there will be deficiency of all these fat soluble vitamins. So the person will present with nyctalopia or night blindness, rickets like manifestations. E deficiency will cause ataxia. K deficiency can cause hemorrhagic tendency. But apart from all these, I want you also to remember a term called as acanthocytes. So if the history says, if you see acanthocyte, steatorrhea, vitamin A, D, E, K deficiency, immediately what will you think of? A beta lipoproteinemia caused by the defect of MTTP protein, triglyceride transport protein. Okay. So apart from these two features, apart from these two conditions, for you to comment on choice C and choice D, let me help you understand about Fredrickson's classification of hyperlipoproteinemias. So, how many types do we have? Fredrickson's classification, there are 6 types. What are the 6 types? Type 1, 2A, 2B, 3, 4 and 5. These are the 6 types. And for you to easily make a diagnosis and for you to easily manage a patient, I am going to stratify these 6 types into 3 categories. The first category presents with only an elevation of cholesterol. The second category presents with only an elevation of triglyceride. The third category presents with an elevation of both. Why do we have to classify it this way? Because clinical features will differ based on this, right? Because if it's a person who presents with only an elevation of cholesterol, then they present with tendon xanthomas and accelerated atherosclerosis. So tell me, what are the manifestations of an elevation of cholesterol? They present with tendon xanthomas and accelerated atherosclerosis. First, let me tell you what are tendon xanthomas. These are small eruptive lesions which are present along the line of attachment of tendons. For example, they are found along the knuckles or they are found along the ankles. Okay, have a look at this. Do you see those features here, those dermatological findings? These are tendon xanthomas found along the knuckles or along the ankles. If you see these in your patient, then suspect hypercholesterolemia. Okay, they also present with accelerated atherosclerosis. Whereas if it's a condition wherein there is an elevation of only triglyceride, then they present with eruptive xanthomas. Tendon xanthomas and eruptive xanthomas are different. And they present with recurrent pancreatitis. Please understand, elevation of triglyceride does not cause accelerated atherosclerosis. What does it cause? It causes recurrent pancreatitis. And on examination, you find lipemia retinalis. So tell me, what are the findings of an isolated elevation of triglyceride, eruptive xanthomas, recurrent pancreatitis, and lipemia retinalis? I know that you're intrigued by the term eruptive xanthomas. What are they? These are even tinier than tendon xanthomas and they're present along the extensor surfaces of your limb. Can you see that here? These are eruptive xanthomas. They are even tinier than tendon xanthomas and they're present along the extensor surfaces of your limb. Okay. So if you see these, it means there is an elevation of triglyceride. Whereas if it's a mixed condition, elevation of both cholesterol and triglyceride, then there will be a mix-up of both these features. Okay. Now, what are the hyperlipoproteinemias which present with an elevation of only cholesterol? That is called as obviously familial hypercholesterolemia and it is type 2A. So all of you tell me, what is type 2A? Type 2A, there is only an elevation of cholesterol. That is why this condition is called as familial hypercholesterolemia. And this is caused by the defect of LDL receptor. And this is an autosomal dominant condition. This can be asked to you as an one-liner. What are the autosomal dominant hyperlipoproteinemias? Type 2A is autosomal dominant. Type 4 and type 5. So tell me, what are the autosomal dominant hyperlipoproteinemias? Type 2A, type 4 and type 5. Now what are the conditions which present with an elevation of only triglyceride? That includes type 1. Okay, not only type 1, type 4 and type 5. How do we remember this? Triglyceridemia is 3, right? So 1 plus 3 is 4. So type 1, type 4, type 5, all these conditions present with an elevation of only triglyceride. So tell me, what are the conditions wherein there is an elevation of both? All left out conditions. What are the left out conditions? Type 2B and 3. Okay, type 2B and 3. Now do you understand why we call type 2B as familial combined hyperlipidemia? Combined hyperlipidemia, because in this condition there is an elevation of both cholesterol and triglyceride. Okay. Type 3. Type 3 is caused by a defect of ApoE. Please memorize it. 3 and E sound similar. Right? 3 and E sound similar. So type 3 hyperlipoproteinemia is caused by the defect of ApoE. And even in type 3 there is an elevation of both cholesterol and triglyceride. Okay, so if you have this classification in mind, when a case-based MCQ is asked, suppose the case history says there is an elevation of only cholesterol, then it is type 2A. If the case history says there is an elevation of both cholesterol and triglyceride, it's 2B or 3. They say there is only an elevation of triglyceride, then it's type 1 or 4 or 5. Okay, So that's about classification of hyperlipoproteinemias. So tell me, what is the right answer here? There is only an elevation of cholesterol. So obviously it is familial hypercholesterolemia, which means what is the right answer here? The right answer here is choice B. Okay. Now tell me about familial combined hyperlipidemia. What is it? It is 2B, wherein there is an elevation of both cholesterol and TGL. Here that's not the case. So this is excluded. ApoE deficiency is type 3 hyperlipoproteinemia. Again, there should have been an elevation of both cholesterol and triglyceride. Again, that's not what you see here. Okay, that is why the answer is choice B. So if you learn every topic in a comprehensive manner with a big picture, okay, with a big picture in mind, however twist is in, how many ever twists are included in the MCQ, you will be able to answer it. Okay. A simple one-liner. I know that most of you know the answer for this MCQ, right? What is the right answer? Drug of choice in mountain sickness. Yes, you're all right. It is acetazolamide. Okay, but I want you to know why. Okay, so let me give you a suggestion, or you can take it as an advice. Whenever you learn a fact, whenever you're told a one-liner, please ask why to yourself. Try to find out the answer. So if you know the why behind every fact that you learn, you will never forget the fact. So why do you think acetazolamide is given for mountain sickness? So in mountain sickness, when the person climbs uphill quickly, the person starts hyperventilating. The person washes away carbon dioxide. And you know, carbon dioxide is the source of an acid. Once a source of an acid is gotten rid of from your body, there's no acid, that causes alkalosis. So what is the acid-base abnormality that you will expect in a patient with mountain sickness? It is respiratory alkalosis. But this respiratory alkalosis is dangerous. Reason is your central chemoreceptors, which are present in the medulla. Okay, we have peripheral chemoreceptors and central chemoreceptors. Central chemoreceptors, which are present in the medulla, respond only to an increase in hydrogen ion concentration in the CSF. So when a person hyperventilates, what happens to CSF hydrogen ion concentration? It decreases. So central chemoreceptors do not get stimulated. So respiratory center will be depressed. Now do you understand why climbing uphill quickly is dangerous? Because of respiratory alkalosis. If that is the primary defect that is observed in mountain sickness, you will have to compare this respiratory alkalosis by giving a drug. And that drug should cause acidosis, right? Only when the drug which you administer or which you give causes acidosis, this can be counteracted. And that is why we give acetazolamide. So how does acetazolamide act? I hope you all remember this. Acetazolamide inhibits carbonic anhydrase enzyme. What if it inhibits carbonic anhydrase enzyme? It inhibits bicarbonate reabsorption in the proximal convoluted tubule. Do you see that here? Acetazolamide inhibits which enzyme? Carbonic anhydrase. So what is not reabsorbed? Bicarbonate is not reabsorbed into the circulation. And bicarbonate is a major plasma buffer. And when one of the plasma buffers is missing, that causes acidosis. So acetazolamide causes, please memorize it, acetazolamide causes normal anion gap metabolic acidosis. That increases hydrogen ion concentration in the CSF. That keeps the central chemoreceptor stimulated and the respiratory center is stimulated. Okay, so what is a drug of choice for mountain sickness? I hope you will not forget this anymore. It is acetazolamide, because acetazolamide causes normal anion gap metabolic acidosis by inhibiting carbonic anhydrase enzyme. Okay, and this is an FMGE December 2021 MCQ. The next one, again a December 2021 MCQ. It's a very simple one-liner. Fat sugar baby is seen in. What's the right answer? Fat sugar baby is seen in kwashiorkor, right? Because edema, okay, edema is a feature of kwashiorkor, and kwashiorkor is caused by deficiency of proteins. This is caused when a child gets fed by carbohydrate rich diet without any proteins. So that causes protein deficiency, and as you all know, proteins maintain oncotic pressure of the circulation. When you don't maintain the oncotic pressure, movement of fluid happens that causes edema. So kwashiorkor is truly a protein malnutrition. Okay. And a similar question was also asked in the very next time in Jan 2022. This was the question. A boy presents with voracious appetite and overall swelling. Do you remember seeing this MCQ? Yeah, so I always say this in all my YouTube sessions. Anyone who watches this session, please take an oath. Yeah, please take an oath. Please take a resolution to attempt as many grant tests as possible. Okay, so when you attempt grant test, first advantage is you will know what is the most important topic that is asked in a particular subject. Step number 2 or advantage number 2 is you will be in touch with all 19 subjects throughout. Yeah, advantage number 3, you will understand the pattern of mistakes which you make. Advantage number 4, most of the grant tests are based on PYQs. So you'll be very familiar with all the PYQs and all the previous year asked topics. Okay, so that way you will always have an edge over others. So don't worry about your performance in any of the grant tests. Grant tests are for improving your performance, not for assessing your performance. Okay, so please attempt as many grant tests as possible. Please go through all previous year questions. So the question here is, a boy presents with voracious appetite and overall swelling, he is most likely to suffer from. The moment anybody sees voracious appetite, they would end up choosing it as marasmus. That is why you should complete the statement. There is also swelling. We know swelling is a feature of kwashiorkor. So you see a mix-up of both the features of marasmus and kwashiorkor. So what is the right answer? The right answer is marasmic kwashiorkor. Okay, to understand why, let me help you by filling up this tabular column. Okay, I'm going to tell you what are the differences between marasmus and kwashiorkor. Then you will understand why the right answer is marasmic kwashiorkor. So what is the cause of marasmus? It is caused by total calorie deficiency. Or in other words, the child is not fed with anything. It is complete calorie deficiency. Whereas kwashiorkor happens when the child is fed with food, but the food is carbohydrate rich, lacks in proteins. So kwashiorkor is caused only by protein deficiency. That's the first difference. Second difference, age. Marasmus is very common in the infantile period. Kwashiorkor happens between 6 months and 3 years. Okay, that's the second difference. The third difference is interesting. It's about appetite. When the marasmic child is not fed at all, what do you think about the appetite? Voracious appetite. Whereas kwashiorkor, the child is fed with something which is not nutritious. So when you feed the child, will the child feel hungry? No. So here there is lack of appetite and the child will be apathetic. Okay, whereas marasmus, there will be irritability. In kwashiorkor, the child will not show any sign of appetite and the child will be apathetic. And then edema, this we know, don't we? When you know that kwashiorkor is protein deficiency, when plasma protein concentration decreases, oncotic pressure is not maintained, so fluid movement happens. So edema is a feature of kwashiorkor. Fatty liver is a feature of again kwashiorkor, not of marasmus. And they say one of the reasons for fatty liver and kwashiorkor is there is lymphatic defect. Okay, so when there is lymphatic defect, the lipid output from the liver gets affected. That causes fatty liver changes. So these are the differences between marasmus and kwashiorkor. And marasmic kwashiorkor is a very severe form of protein energy malnutrition. When it starts with protein malnutrition, then it progresses to total calorie deficiency. And in marasmic kwashiorkor, you'll find features of both these malnourishment conditions. And in marasmic kwashiorkor, the weight of the child will be less than 60% of ideal weight. Usually, if it's only kwashiorkor, the weight will be between 60 and 80% of ideal weight because of the presence of edema. In marasmic kwashiorkor, in spite of there being an edema, the weight is less than 60% of the ideal weight. That's called as marasmic kwashiorkor. Okay. So you have learned 2 facts. Sugar baby syndrome is kwashiorkor. Kwashiorkor presents with edema. Kwashiorkor is protein deficiency. Marasmus is total calorie deficiency. Okay. A very simple, I would say it's a one-liner, but using this one-liner, I'm going to help you understand few facts. Okay, so watch this carefully for the next 1 minute, 1 or 2 minutes. So which of the following has the lowest glycemic index? Many of you might think it's watermelon, because watermelon is supposed to not cause weight gain, and many of us eat watermelon right and left to avoid weight gain, but if you want to fill up your stomach, right? But watermelon has got a high glycemic index. So let me tell you the values of glycemic index. The answer for this is sweet corn, because the glycemic index of sweet corn is 55. If a food's glycemic index is less than or equal to 55, then it's supposed to have a lower glycemic index. So what about watermelon? Interestingly, it is 72. Papaya is 60. Okay, potato, the glycemic index of potato would differ based on what kind of potato it is. Sweet potato has got lower glycemic index, whereas white or yellow potato will have moderate or higher glycemic index. And it's also dependent on the way the potato is cooked. Fries will have higher glycemic index, boiled potatoes relatively lesser. But if it's a boiled white or yellow potato, not the sweet one, if it's boiled white or yellow potato has got 82 as the glycemic index. So which has got the lowest glycemic index? It's sweet corn. Okay, so a bit about glycemic index. It's expressed as a percentage. So every food will be assigned a number of glycemic index between 0 and 100. Okay, and reason is it is nothing but a relative increase in plasma glucose 2 hours after ingestion of 50 gram of that particular food, when compared to the rise in plasma glucose 2 hours after ingestion of 50 grams of glucose. So it's a relative value which is expressed as a percentage. And based on glycemic index, you can categorize food items into 3 types. Those with lower glycemic index, moderate glycemic index, and higher glycemic index. Less than or equal to 55 is lower glycemic index. 56 to 69 is moderate glycemic index. 70 and above is higher glycemic index. Let me give you examples for all these 3 categories. Lower glycemic index is fructose. Okay, so please don't get confused between high fructose corn syrup and fructose. Fructose just as a substance has got lower glycemic index. Whereas high fructose corn syrup has got higher glycemic index. Not only fructose, anything which we know is good for us. We know consumption of vegetable is good for us because vegetables are rich in fiber. They reduce the rate at which plasma glucose increases. Even fruits, even fruits which are supposed to cause weight gain, like mangoes, they have lower glycemic index. Okay, so vegetables, fruits, nuts, okay, and then seeds. That is why people hog on seeds. Have you seen people having sunflower seeds, flax seeds? So all these seeds, pumpkin seeds, all these have lower glycemic index because of their higher fiber content. So nuts, seeds, whole grains. If you can consume whole wheat, whole oat, whole barley, that has got lower glycemic index. And peeled sweet potato. Okay, peeled sweet potato also has got lower glycemic index. Now, what are the food items which have moderate or medium glycemic index? Sucrose. Fructose has got low, sucrose has got medium glycemic index. But apart from sucrose, you should also remember peeled sweet potato. Okay, peeled sweet potato, unpeeled yellow or white potato, basmati rice. Okay, so all these have medium glycemic index. Now, what are the food items which have higher glycemic index? All that we consume. Okay, all that we consume in the sense, starting from, as I told you, high fructose corn syrup, which is present in many of the processed food. Okay, for example, breakfast cereals. Many say, I don't eat idli or dosa for my breakfast, I just take cereals, still I keep gaining weight. Please remember, breakfast cereals, it's highly processed. So the glycemic index is very high. White rice. Okay, white rice has got high glycemic index. Glucose, if it's just glucose, too bad. Okay, and then white rice. So all these have high glycemic index. Okay. Now, what is the right answer here? So even if it's not helpful for you to answer an MCQ, an understanding of that will help you to keep you healthy. Okay. So, which of the following has the lowest glycemic index? Answer is sweet corn. It is 55. A very good question. The micronutrient that is deficient following ileal resection is, and this is an FMGE June 2021 question. They are indirectly asking you which of the following gets absorbed in the terminal ileum. Which gets absorbed in the terminal ileum when most of the nutrients get absorbed in the upper small intestine. For example, iron gets absorbed in duodenum. So most of the nutrients get absorbed in the upper small intestine. Only B12 gets absorbed in the terminal ileum. And that is why one of the causes of B12 malabsorption is Crohn's disease. Don't we know that? Crohn's disease or regional ileitis causes ileal damage. When there is ileal damage, B12 absorption gets affected. Okay. A very simple case-based MCQ which was asked in June 2021. That was the first time wherein FMG started asking you more of case-based MCQs. A vegetarian patient presents with anemia and hypersegmented neutrophils. The most probable cause is, the first clue given to you is vegetarian patient. Okay, so B12, most of the sources of B12 are non-vegetarian. So vegans are more prone to develop B12 deficiency. And a vegan or a vegetarian has presented with anemia and hypersegmented neutrophils. What are hypersegmented neutrophils? Presence of neutrophil with more than or equal to 6 lobes in the nucleus. Yeah, more than or equal to 6 lobes in the nucleus. That's called as hypersegmented neutrophil, and that's the first sensitive finding for megaloblastic anemia. Okay, so what is the right answer here? Vegetarian patient presenting with anemia and hypersegmented neutrophil is a sign of megaloblastic anemia. So why should B12 deficiency present as megaloblastic anemia? Have you ever thought about it? Please always ask yourself why. So why should B12 deficiency cause megaloblastic anemia? Have you heard of methylfolate trap? Whenever there is B12 deficiency, indirectly it causes deficiency of tetrahydrofolate. And tetrahydrofolate is necessary for forming purine and pyrimidines. So when there is no folate, purines and pyrimidines cannot be synthesized. Without purines and pyrimidines, nuclear division is not possible, right? Without purines and pyrimidines, replication cannot happen. Without replication, nucleus cannot divide. But cells keep growing, they are not able to divide. That is why larger cells, macrocytic anemia, nucleus is not dividing. That is why hypersegmented neutrophils. Okay, so that's about megaloblastic anemia caused by B12 deficiency in a vegetarian. This, I would say, is the most frequently asked topic, right? They ask you this as an image-based question or as a case-based question or as an one-liner. A person presents with diarrhea, dermatitis and dementia. So what are these three? These three are 3 Ds of pellagra. Yeah, diarrhea, dermatitis, dementia. How do you think an image-based question can be framed on this? Dermatitis is photosensitive dermatitis. So any sun-exposed area, you will see scaly, hypertrophic lesions. Okay, so that's called as Castle's necklace. So if you are shown Castle's necklace, then what is your diagnosis? It's 3 Ds of pellagra caused by niacin deficiency. So what is the right answer here? It is choice A. Okay, for completion's sake, let me also tell you about the other choices a bit. Cystinuria. This is not cystinuria. How should you pronounce it as? It's a cystinuria. Cystinuria is caused by the defect of a neutral amino acid transporter in the proximal convoluted tubule. And this neutral amino acid transporter is common for reabsorbing 4 amino acids along the PCT. How can you remember those 4 amino acids? They can be remembered using a mnemonic COLA. So what does COLA stand for? Cysteine, ornithine, lysine and arginine. Okay, cysteine, ornithine, lysine, arginine, COLA amino acids get reabsorbed along the PCT through a common transporter. When that transporter is defective, all these 4 amino acids will be found in the urine. When there is excess cysteine, cysteine has got sulfhydryl group. When there is excess cysteine, two cysteine molecules will condense with each other to form cysteine. Okay, this is called as cysteine with disulfide bridge, and this is insoluble in water, so it gets precipitated in urine. So in the urinary tract, cysteine gets precipitated, that causes renal stones. So tell me, what will be the manifestation of cystinuria? Remember, cysteine is insoluble in urine, gets precipitated along the urinary tract, causing recurrent renal stones or as recurrent obstructive uropathy. Okay, alkaptonuria, I know all of you know. Please do not attend your FMG clearance exam if you have not learnt about alkaptonuria, because alkaptonuria gets frequently asked about. Okay, so alkaptonuria is caused by the defect of homogentisate oxidase. So what are the facts that you need to know about alkaptonuria? Cause. What is the cause? Homogentisate oxidase defect. So what accumulates? Homogentisic acid accumulates, that undergoes oxidation to form benzoquinone acetate, which undergoes polymerization to form melanin-like fibrils. And these melanin-like fibrils are black in color. They get deposited on cartilages. That causes cartilage destruction, and that is called as euchronosis. So what will be the clinical presentation of alkaptonuria? It will present as a middle-aged person coming to you with multiple intervertebral disc bulges or prolapses or multiple joints involvement. And these melanin-like fibrils also form in the urine. So urine turns dark on standing. That is why the name alkaptonuria. Alkapton means black. It is black urine disease. And melanin-like fibrils accumulate in the skin. That is why you see pigmentation of the skin. Yeah, pigmentation of thenar and hypothenar eminences will be observed. Pinna, tip of the nose, all these will be pigmented. And these pigments also accumulate in the mucous membrane, and that causes Osler's sign. Okay, so Osler's sign is the first sign of alkaptonuria. Okay. And there is another MCQ on porphyria. I will be discussing about that in under 10 to 15 minutes. Okay, for now, what is the right answer? The right answer is pellagra. Okay, so this is how I want you to work out PYQs. When you read about PYQ, it is not just enough if you know the right answer. You will have to learn about every choice that is provided. You will have to know how is this choice excluded. Okay, a good question, because usually they ask you questions on Wilson's disease. Instead, in FMG June 2021, they decided to ask you about Menkes disease. Both are related to copper. One is copper deficiency, the other one is copper toxicity, right? So Menkes disease is caused by copper deficiency. Wilson's disease is caused by copper toxicity. Okay, so let me tell you a few facts about Menkes disease. It's caused by the defect of ATP7A transporter. And the function of ATP7A is to cause absorption of copper and to cause incorporation of copper into many of the copper dependent enzymes. So when there is no absorption of copper along the intestine, what do you expect? Copper deficiency, right? That is one effect. When it's not getting incorporated into copper dependent enzymes like lysyl oxidase. Please remember, one of the copper dependent enzymes is lysyl oxidase, which is involved in collagen cross linkage formation. This was asked in FMG Jan 2023. Yeah, in the just in the Jan 2023 MCQ, they asked you, collagen cross linkage formation is dependent on what? Answer should be copper and vitamin C. Please memorize it. Collagen cross linkage formation is dependent on both copper and vitamin C. Why copper? Because copper is necessary for lysyl oxidase. So when there is copper deficiency, no incorporation of copper, lysyl oxidase and ceruloplasmin will be defective. Without lysyl oxidase, collagen cross linkages are not formed, and that is why you find kinky hair, Menkes kinky disease, right? So kinky hair, there will be repetitive fractures, hypotonia. Okay, so these are the manifestations of Menkes disease. So compare and contrast between Menkes disease and Wilson's disease. Wilson's disease is ATP7B mutation. Okay, Menkes is 7A mutation. A is related to absorption of copper. ATP7B is related to secretion of copper into the bile. So when there is no secretion of copper into the bile, that causes copper toxicity, hepatolenticular degeneration. Yeah, it presents as hepatolenticular degeneration. Okay. So Menkes Wilson's, which is the first alphabet. When you go through A, B, C, D, E, what comes first? Menkes comes first. 7A comes first. Okay. Wilson's is ATP 7B. A for absorption, B for bile, secretion of copper into bile. So one is copper deficiency, the other one is copper toxicity. Okay. Cholesterol is synthesized from what? Acetyl-CoA, bile acids, phenylalanine, heme. It is acetyl-CoA. Cholesterol is synthesized from acetyl-CoA. So let me tell you that acetyl-CoA is a common precursor. Yeah, it is a central metabolite. It can have multiple fates. The major fate of acetyl-CoA is that it gets into citric acid cycle and it comes out as carbon dioxide. Yeah, what is a major fate of acetyl-CoA? It gets into citric acid cycle, gets burnt out and comes out as carbon dioxide. Second fate of acetyl-CoA, two molecules of acetyl-CoA will condense to form ketone bodies. Okay, acetoacetate is formed from acetyl-CoA. Third fate of acetyl-CoA, when there is high energy, acetyl-CoA is not going to get into citric acid cycle. It need not be broken down. Acetyl-CoA will not get into ketone body synthesis as well, and acetyl-CoA will enter into anabolism. And acetyl-CoA is the building block of both fatty acid and cholesterol. Okay, acetyl-CoA is the building block of both fatty acid and cholesterol. So tell me, what is the right answer here? Cholesterol is synthesized from acetyl-CoA. Now what about bile acids? Bile acids are synthesized from cholesterol. Do you understand this? Bile acids are synthesized from cholesterol. So cholesterol is a steroid. Cholesterol in the presence of 7-alpha hydroxylase becomes bile acids. Okay. Phenylalanine does not form cholesterol. Phenylalanine can form tyrosine. Right? From phenylalanine you get tyrosine. Okay. A very simple conceptual MCQ. Still some students made a mistake when it was asked in June 2021, and that is why I thought this question should be included here. So what happens after a meal? Simple answer. After a meal, plasma glucose increases. The moment plasma glucose increases, pancreatic beta cells will respond to it by releasing insulin. Okay, and pancreatic beta cells will direct alpha cells to not release glucagon. So what will you see after a meal? Hyperglycemia. To combat hyperglycemia, insulin will be released and glucagon will not be secreted. So what will you observe? Increase in insulin and decrease in glucagon. Which of the following activities is low in riboflavin deficiency? So vitamin deficiency investigations are being frequently asked. So let's take some time in understanding about vitamin deficiency investigations. If you suspect riboflavin deficiency, you have to estimate RBC glutathione reductase activity. So what is the right answer here? It is RBC glutathione reductase activity. If you're asking me how to memorize it, don't you know that ribbon and glue go hand in hand as far as art and craft is concerned? Yeah, art and craft, ribbon and glue. Yeah, glue and ribbon, they always go hand in hand. So riboflavin deficiency, what will you estimate? RBC glutathione reductase activity. Now how about transketolase? When will you estimate RBC transketolase activity? Whenever you suspect B1 deficiency. Okay, so tell me, if you suspect B1 or thiamine deficiency, you will estimate RBC transketolase activity. Glycogen phosphorylase is dependent on B6. Okay, glycogen phosphorylase, an enzyme of glycogenolysis, is dependent on B6. Okay, and because we have started discussing about B6 or pyridoxal phosphate, if you suspect B6 deficiency, what is the last letter for 6? X. Yeah, if you suspect B6 deficiency, what will you estimate in urine? You will estimate xanthurenic acid level in urine. Okay, you'll estimate xanthurenic acid level in urine. After X, what is the alphabet? Y. So you estimate xanthurenic acid level in urine after tryptophan load. Okay, have you understood this? If you suspect B6 deficiency, what will you estimate in urine? You estimate xanthurenic acid level in urine after tryptophan load. Okay, so that's about choice B. Propionyl-CoA carboxylase is dependent on biotin. All of you note this down. Carboxylases, carboxylases. It can be any carboxylase. It can be pyruvate carboxylase or propionyl-CoA carboxylase, any carboxylase for that matter. If you see the term carboxylase in an enzyme's name, you can close your eye and say it needs BBA. What does it need? BBA. What does BBA stand for? The first B stands for biotin. So tell me, what is a coenzyme that is necessary for all carboxylases? It is biotin. Second B stands for bicarbonate. Carboxylases need carbon dioxide. What acts as a source of carbon dioxide? Bicarbonate. A stands for ATP. So tell me, what are the three requirements of any carboxylase? BBA. What does BBA stand for? Biotin, bicarbonate and ATP. Okay. So that's all about vitamins which you need to know. These are essential aspects of vitamins that are getting frequently asked about. This, I would say, is a tough question. Okay. The question was the enzyme that is released in hypothalamus. Even if you don't answer such MCQs, if it's asked for the first time in your exam, please don't feel bad. Okay, please don't feel bad. Such MCQs you don't have to answer correctly. Okay, or not, it's not mandatory that you will have to answer this to clear FMG exam, or even if it's asked in NEET PG, you don't have to worry about it. Okay, so the answer here is hexokinase 4. The enzyme that is released in hypothalamus is hexokinase 4. So what is hexokinase 4? This is actually glucokinase. We always learn about differences between hexokinase and glucokinase. Actually, hexokinase has got 4 isoforms, 1, 2, 3, 4. Out of these, the 4th isoform is called as glucokinase. So for completion's sake, I'm going to tell you about differences between hexokinase and glucokinase, because they always cover the same topic or similar topics. Okay. So the first difference between hexokinase and glucokinase is location. Hexokinase is present in all cells. Whereas glucokinase is present in liver and in pancreatic beta cells. Okay, hexokinase is present in all cells, but glucokinase is present in liver and in pancreatic beta cells. But the same glucokinase is also found to be released by hypothalamus and by enterocytes. Now do you understand why I said the answer for this question is hexokinase 4? Because glucokinase is released by liver, pancreatic beta cells, hypothalamus and enterocytes. Okay. The second difference is based on Km and affinity. The special enzyme which I told you is present in very few cells. They exhibit lower affinity. They exhibit lower affinity or higher Km. For now, all of you please remember, affinity and Km are inversely proportional. Similar to affinity and P50 being inversely proportional. Okay. So lower affinity or higher Km will be a feature of glucokinase, whereas hexokinase exhibits higher affinity and lower Km. Third difference is inhibition by glucose 6-phosphate. What is the function of hexokinase and glucokinase? Both hexokinase and glucokinase will allow glucose to react with ATP to form glucose 6-phosphate and ADP. So what is the product of both hexokinase and glucokinase? It is glucose 6-phosphate. And most of the enzymes get inhibited by their products. So hexokinase is inhibited by glucose 6-phosphate. But glucokinase is not inhibited by glucose 6-phosphate. So always remember, glucokinase is a special enzyme. It has got a special location: liver, pancreatic beta cells, hypothalamus, enterocytes. And it exhibits lower affinity, higher Km. It is not inhibited by its product like how it happens for all other cells. It's not inhibited by glucose 6-phosphate. Instead, glucokinase is inducible by insulin. Yeah, glucokinase is inducible by insulin. So these are the differences between hexokinase and glucokinase. And what is the right answer for that question? The enzyme that is released by hypothalamus is hexokinase 4 or glucokinase. Okay. So another FMG Jan 2023 MCQ. A post-menopausal woman presents with pain in the first metatarsophalangeal joint following intake of alcohol. So can you summarize it so far? First, metatarsophalangeal joint. What is the clue? It is gout, gouty arthritis. And you know, gout gets precipitated by alcohol. Okay. The drug that should act, the drug used should act by inhibiting which of the following enzymes? The drug which the person consumes should reduce uric acid formation. How can you reduce uric acid formation? We know for sure that uric acid precursor is xanthine. Only when xanthine oxidase acts on xanthine, it gets converted to uric acid. So if you can inhibit xanthine oxidase, uric acid levels will be low. So what is the right answer? The right answer is xanthine oxidase. Peripheral conversion of T4 to T3 is done by what? Simple question, right? So peripheral conversion of T4 to T3, what does it mean? Which is the major hormone that is released by all your thyroid follicular cells? Major hormone that is released is T4. But which is the active form of thyroid hormone? T3 is the active form of thyroid hormone. So what are you supposed to do? You should convert T4 to T3. That is done by deiodinases. So what is the right answer here? The right answer here is deiodinase. Thyroid peroxidase is the enzyme which catalyzes every step involved in T4 synthesis. Do you understand this? Thyroid peroxidase starts from converting iodide to iodine. Then it helps in iodination of tyrosine residues to form monoiodotyrosine and diiodotyrosine. The same thyroperoxidase enzyme causes coupling of these iodotyrosine residues to form thyronin hormones. But after thyronin hormones are formed, for conversion of T4 to T3, you need deiodinase. And is there anything else that comes into your mind the moment you hear the term deiodinase? Deiodinase is a selenium dependent enzyme. Okay, so deiodinase is a selenium dependent enzymes. And what are the other selenium dependent enzymes? The other selenium dependent enzymes include thioredoxin reductase. Number 1 is thioredoxin reductase. Number 2 is deiodinase. Okay. And then we have glutathione peroxidase. So don't get confused here. Glutathione reductase is used for glue and ribbon. Glutathione reductase activity is used for measuring what? Riboflavin deficiency. Selenium dependent enzymes are glutathione peroxidase, thioredoxin reductase and deiodinase. A middle-aged patient, again FMG Jan 2023 MCQ. I would say this is a very conceptual MCQ. I have not seen such an MCQ even in INI-CET. Okay, so and hats off to the one who set this question, because only that question which is capable of understanding if a student has learned something conceptually is the right form of question. Okay, that's what I believe in. So a middle-aged patient presented with high anion gap metabolic acidosis and is diagnosed with defect of pyruvate dehydrogenase complex. Which of the following dietary advice would you prescribe? Okay, so what if there is a defect of pyruvate dehydrogenase complex? What does PDH complex normally do? Anybody? Normally PDH complex converts pyruvate into acetyl-CoA. What after it forms acetyl-CoA? Acetyl-CoA enters into citric acid cycle, comes out as carbon dioxide. From where do you get pyruvate? Glucose, right? Carbohydrates get broken down to form glucose. Glucose, when it gets into glycolysis, would form pyruvate. So do you understand this entire integration of metabolism? You start from glucose, you convert glucose into pyruvate. Then PDH complex converts pyruvate into acetyl-CoA. Then acetyl-CoA enters into citric acid cycle, comes out as carbon dioxide. But the pyruvate that is formed from glucose does not only become acetyl-CoA when lactate dehydrogenase. When lactate dehydrogenase acts on pyruvate, it gets converted to lactate. Now tell me what is expected when there is PDH complex defect. When there is a defect of PDH complex, the accumulated pyruvate will get converted to lactate. Lactate is an acid. Acid accumulation will cause increased anion gap metabolic acidosis. Now you don't want your patient to suffer from increased anion gap metabolic acidosis, which means you should reduce the formation of pyruvate. How can you reduce the formation of pyruvate? By giving carbohydrate restricted diet. Don't you think it's logical? Yeah, so what is a dietary recommendation that you should give for a patient who suffers from PDH complex defect? A carbohydrate restricted diet. Okay, now look at these 4 choices. Only carbohydrate intake henceforth. Would you suggest that? Definitely no. High carbohydrate, low fat intake? No. High fat, low carbohydrate diet or high protein, low carbohydrate diet? We are very clear about low carbohydrate diet, but but is it going to be high fat or high protein? I would say it should be a high fat, low carbohydrate diet. Why? Because even if the person consumes high protein, proteins on breakdown will give rise to amino acids. And many of the amino acids on catabolism enter into glycolysis or they form pyruvate directly. In that case, when PDH complex is defective, this pyruvate should also become lactate. So this is not going to serve the purpose. So tell me, what would you recommend for a patient who has got PDH complex defect? It is low carbohydrate, high fat diet. Because if it's fatty diet, all fats get broken down to give acetyl-CoA. Even if there is a block above this, it's not going to cause any accumulation. Okay. So what will you recommend? You have to recommend low carbohydrate, high fat diet. Again an FMGE Jan 2023 MCQ. This is about genetics. Okay, I'm happy that in FMG they've started asking you genetics based questions as well. So in liver, ApoB gene is completely translated to ApoB100 and in intestine it is translated to ApoB48. Didn't I tell you about this already? Yeah, I was telling you that chylomicron has ApoB48. Didn't I tell you? Whereas VLDL has got ApoB100. And where is chylomicron formed? Chylomicron is formed in intestine. Whereas VLDL is formed in liver. So ApoB48 is a protein that is formed in intestine. ApoB100 is a protein that is formed in liver. But interestingly, the statement says it is formed from a common gene, which is ApoB gene. So how can one gene give rise to different protein products is the question. So which of the following mechanisms explains this? What is the right answer? Many of them ended up answering it as gene splicing. This is not gene splicing. This is because of RNA editing. Yeah, what is responsible for this? It is RNA editing. Let me help you understand what is RNA editing. For that, please answer few of my questions first. ApoB48 is an apoprotein of which lipoprotein? Chylomicron. Where is chylomicron formed? Enterocytes. Whereas ApoB100 is an apoprotein of VLDL. Where is VLDL formed? In hepatocytes. But both these are products of one common gene. What is that common gene called as? That common gene is ApoB gene. So how can one gene give rise to different protein products in different tissues? Interestingly, in both these tissues, in both enterocytes and hepatocytes, this ApoB gene undergoes the same transcription to form the same mRNA. This mRNA undergoes same 3 post-transcriptional modifications. I hope you all remember genes on transcription will form mRNAs, right? And after transcription, modifications happen to give rise to functional mRNAs. Okay, so the functional mRNA that is formed in both enterocyte and hepatocyte is the same. These functional mRNAs come out of nucleus and they reach the cytoplasm. Okay, so these functional mRNAs come out of nucleus and they reach the cytoplasm in both enterocyte and in hepatocyte. But there is a change that happens only in enterocytes. Enterocytes have an enzyme by name cytidine deaminase. Repeat it along with me. What is the enzyme that is present in enterocyte? It is cytidine deaminase. And this cytidine deaminase deaminates cytidine of a codon CAA here. In both the functional mRNAs, there is a codon CAA. In hepatocyte, it stays as CAA. In enterocyte, there is an enzyme cytidine deaminase, which deaminates cytidine of a codon CAA to form UAA. And what is UAA, all of you? If you know the answer, please type that in the chat box. UAA is a stop codon. So in enterocyte, a stop codon gets prematurely inserted. So there is premature termination of protein synthesis in enterocyte. Whereas in hepatocyte, the whole protein gets synthesized. Okay, so the truncated protein that is synthesized in enterocyte has got only 48% of amino acids that is synthesized in hepatocyte. And that is why the truncated protein is called as ApoB48 and the whole protein is called as ApoB100. Have you understood this? So this tells you how can one gene give rise to different protein products in different tissues. And why is it called as RNA editing? Because you edit some of the nucleotide sequences of the fully formed mRNAs only in specific tissues. Why is it RNA editing? What do we edit? You edit some of the nucleotide sequences of the fully formed mRNAs only in specific tissues, so that the protein that you get out of them get altered only in specific tissues. That's why it's called as RNA editing. So please don't forget three facts. The first fact is ApoB48 formation is an example of RNA editing. Second fact is the enzyme that is responsible for RNA editing and ApoB48 formation is cytidine deaminase. Third fact, cytidine deaminase is present only in enterocytes. Okay, so that's all about this MCQ. So what is the right answer? The right answer is RNA editing. A Jan 2022 MCQ. Atrial natriuretic peptide acts through what? Both atrial natriuretic peptide and nitric oxide act on a receptor. They go and bind to a receptor, and this receptor has got guanylyl cyclase activity. Adenylyl cyclase converts ATP to cyclic AMP. Guanylyl cyclase converts GTP to cyclic GMP. So ANP and nitric oxide act through what? Cyclic GMP. Okay. And for completion's sake, what are the chemical messengers which act through cyclic AMP? Cyclic AMP dependent receptor activity has been frequently asked. You should definitely remember glucagon. Okay, glucagon acts through cyclic AMP because glucagon acts through GS receptor, wherein S stands for stimulating adenylyl cyclase, which forms cyclic AMP. Not only glucagon, beta adrenergic receptors, okay, parathormone receptor, ACTH. If you remember these four, that is good. That is more than enough. So tell me, what are the chemical messengers receptors of which act through cyclic AMP? It is glucagon, beta adrenergic receptors, parathormone and ACTH. IP3 and DAG. I told you GS acts by stimulating adenylyl cyclase. GQ receptor acts by activating phospholipase C. And this phospholipase C forms IP3 and DAG. So what are the IP3 DAG receptors? Alpha 1. Yeah, all 1 receptors. What are the 1 receptors? Alpha 1, M1, M3. Okay, alpha 1, M1, M3. All these are GQ couple receptors. They act through IP3 and DAG. Tyrosine kinase, very simple. Tyrosine kinase receptor would be insulin. Okay, answer is insulin. Which of the following pathways only takes place in a cell's cytoplasm? A simple one-liner, but there can be many questions that are asked based on this. So which of the following pathways only takes place in a cell's cytoplasm? It is glycolysis. Because glycolysis is the only oxidation that is anaerobic. Every other oxidation is aerobic, and aerobic oxidation is bound to happen in mitochondria. Okay, so glycolysis happens in cytoplasm. How about beta oxidation of fatty acids? Oxidation of fatty acid, oxidation happens in mitochondria. But do you think all fatty acids undergo oxidation in mitochondria? No. Very long chain fatty acids undergo oxidation in peroxisomes. So beta oxidation of fatty acids happen predominantly in mitochondria, but they also happen in peroxisomes. So what are the other functions of peroxisome? This is a favorite topic of FMGE. So one function of peroxisome is very long chain fatty acid oxidation, but apart from that, ether lipid synthesis. You must have learned it as plasmalogen synthesis. Okay, ether lipid synthesis. Glycine and taurine conjugation of bile acids. The next one is glycine and taurine conjugation of bile acids. They are also necessary for apart from plasmalogen synthesis, they are also necessary for branch chain fatty acid oxidation. So tell me, what are the functions of peroxisomes? Peroxisomes are concerned with very long chain fatty acid oxidation, branch chain fatty acid oxidation, ether lipid synthesis, glycine and taurine conjugation of bile acids. Okay, where does citric acid cycle happen? Citric acid cycle is the final oxidation process wherein every fuel comes and gets burnt out. If it's a final oxidation process, where is it bound to happen? Mitochondria. Okay, citric acid cycle happens in mitochondria. How about urea cycle? It's interesting. Urea cycle, 2 steps happen in mitochondria. Remaining steps happen in cytoplasm. So all of you memorize this. Heme synthesis, okay, heme synthesis and urea cycle happen partly in mitochondria, partly in cytoplasm. Okay, so can we fill up this tabular column? If you fill up this tabular column, then it means any question that is asked based on pathways and suborganelles, you will be able to answer. Okay, so let's start with glycolysis. Glycolysis happens in cytoplasm. Pyruvate dehydrogenase complex is present in mitochondria. Citric acid cycle happens in mitochondria. Glycogen metabolism includes glycogen synthesis and glycogenolysis. Both these pathways happen in cytoplasm. Gluconeogenesis, it's interesting. Gluconeogenesis involves multiple suborganelles. The first enzyme of gluconeogenesis is in mitochondria. The remaining enzymes of gluconeogenesis are present in cytoplasm. But the last enzyme, glucose 6-phosphatase, is present in endoplasmic reticulum. So gluconeogenesis involves multiple suborganelles. It happens in mitochondria, cytoplasm and in endoplasmic reticulum. Okay, and if they ask you which is the enzyme that is present in endoplasmic reticulum, your answer should be glucose 6-phosphatase, the last enzyme of gluconeogenesis. That means if they ask you which is the microsomal enzyme marker, what do you mean by microsomes? They are endoplasmic reticulum. So microsomal enzyme marker is also glucose 6-phosphatase. Okay, that's about gluconeogenesis. HMP shunt also happens in cytoplasm. Fatty acid synthesis happens in cytoplasm. Fatty acid oxidation. What did I tell you about fatty acid oxidation? Happens in mitochondria predominantly, but very long chain fatty acid oxidation happens in peroxisomes. Ketone body synthesis. What are ketone bodies? Ketone bodies are products of incomplete oxidation of fatty acids. Where are fatty acids oxidized? Mitochondria. So where do you think ketone bodies get synthesized? In mitochondria. Cholesterol synthesis. Cholesterol is a steroid, right? Cholesterol is a steroid. Do you remember that smooth endoplasmic reticulum is related to steroid synthesis? Yeah. Rough endoplasmic reticulum is related to protein synthesis. Smooth endoplasmic reticulum is related to steroid synthesis. So cholesterol synthesis or steroid synthesis happens in smooth endoplasmic reticulum partly and partly in cytoplasm. Bile acid synthesis, that is another steroid which gets synthesized in smooth endoplasmic reticulum. Urea cycle, just now I told you, both urea cycle and heme synthesis happen partly in cytoplasm, partly in mitochondria. Okay, so after you watch this video once, come back and watch this again. Memorize all the facts that are provided to you here and understand all the concepts that are provided here. My assurance is most of the biochemistry based MCQs you'll be able to answer. Okay. Which of the following is not a micronutrient? Another Jan 2023 MCQ. Calcium. Right? Calcium is not a micronutrient. What is a micronutrient? Based on RDA. If the daily requirement of a nutrient is less than 100, if the daily requirement of a nutrient is less than 100 milligram, then that is called as micronutrient. The best example for micronutrients would be vitamins. Not only vitamins, iron, zinc, copper, okay, iron, zinc, copper, manganese, molybdenum. All these are micronutrients. So what are the micronutrients? Starting from vitamins, iron, copper, zinc, molybdenum and manganese. So what are macronutrients? If the requirement is more than 100 milligram per day, that's called as a macronutrient. Example will be calcium, right? Calcium, magnesium, phosphorus, potassium. So all these are macronutrients. Okay. Another Jan 2023 MCQ. Melanin is synthesized from which of the following amino acids? Don't you all know that tyrosinase is the enzyme which forms melanin? And that is why tyrosinase defect causes albinism. Right? Tyrosinase deficiency causes albinism because tyrosinase is the enzyme which converts tyrosine to melanin. So melanin synthesized from what? Tyrosin. Now, apart from tyrosine forming melanin, what are the other specialized products that you get from tyrosine? Tyrosine is a precursor for neurotransmitters. What are the neurotransmitters? Dopamine, norepinephrine, epinephrine. Right? Dopamine, norepinephrine, epinephrine. All these are synthesized from tyrosine. And just few minutes back when I told you about deiodinases, I told you tyrosine undergoes iodination to form iodotyrosin residues that undergo coupling to give rise to thyronin hormones. So from tyrosine you also get thyroid hormones. So what are the specialized products that you get from tyrosine? Melanin, neurotransmitters dopamine, norepinephrine, epinephrine and then thyroid hormone. So what is that you get from tryptophan? From tryptophan you get 5-hydroxytryptophan, which undergoes decarboxylation to form 5-hydroxytryptamine. So what is 5-hydroxytryptamine? It is serotonin. So from tryptophan you get serotonin. From tryptophan you get niacin. You must have learned that 60 milligram of tryptophan is equivalent to 1 milligram of niacin. So from tryptophan you get niacin and serotonin. And there is nothing much that you get from leucine. All that you will have to remember about leucine is both leucine and lysine are purely ketogenic. Okay, both leucine and lysine are purely ketogenic. Didn't I tell you? Yeah, the frequently asked topic. This is the frequently asked image based MCQ. Given picture depicts the deficiency of. What is that you see here? Castle's necklace. And what is Castle's necklace? It's a feature of pellagra. And pellagra is caused by niacin deficiency. So given picture depicts the deficiency of niacin. Okay. So B3 is niacin. Niacin is characterized by 3 Ds of pellagra. Okay. B3 is niacin. It is characterized by 3 Ds of pellagra. And had they tried giving you an image-based question on retinol, yeah, vitamin A, what is the image that can be shown? They can show you white dot spots. So what is this? White foamy triangular patches that are seen along the limbus, right? This is nothing but keratin debris. I will tell you about the eye manifestations of vitamin A deficiency in some time. For now, retinol, if there is an image-based question, it's going to be white dot spots. Riboflavin. What do you think is the deficiency manifestation of riboflavin? Yes, angular stomatitis or angular cheilitis. Right, angular stomatitis or angular cheilitis. Also remember that the first sign of riboflavin deficiency is circumcorneal congestion. Okay, the first sign of riboflavin deficiency is circumcorneal congestion. You know the answer already. I've told you this. A child presents with complaints of, do you understand? We are just seeing the last 5-year question papers. Already we are seeing repetition. Okay, that is why you will have to be very clear about all PYQs. A child presents with complaints of urine turning dark on standing. It is caused by the deficiency of urine turning dark on standing is alkaptonuria. What did I tell you about alkaptonuria? Caused by the deficiency of homogentisate oxidase. For completion's sake, I am going to tell you about the other choices as well. Branch chain keto acid dehydrogenase deficiency. Okay, branch chain keto acid dehydrogenase deficiency causes maple syrup urine disease, which is characterized by maple syrup odor or burnt sugar odor. Also remember, branch chain keto acid dehydrogenase is dependent on thiamine, and that is why maple syrup urine disease responds to thiamine administration. Okay. Isovaleric-CoA dehydrogenase deficiency causes isovaleric acidemia. And this isovaleric acidemia is characterized by sweaty feet odor. Yeah, it is characterized by sweaty feet odor. I have already given you this in one of my previous YouTube sessions. Okay, how to remember this? I showed you an image wherein feet are kept on the ice. Yeah, feet are kept on the ice. So isovaleric acidemia, feet, sweaty feet odor. Okay. Glutathione synthetase deficiency causes 5-oxoprolinuria. Glutathione synthetase deficiency causes 5-oxoprolinuria. A June 2022 MCQ. Which of the following is a complex 4 inhibitor of electron transport chain? Complex 4 is inhibited by, I want you to remember the last complex is complex 4, which transports electron from 4 to oxygen. That is inhibited by all common poisons. What are the common poisons? Hydrogen sulfide, cyanide and carbon monoxide. Okay, hydrogen sulfide, cyanide and carbon monoxide. So what is the right answer here? Cyanide. Now tell me about amobarbital. What is the first alphabet of amobarbital? A. And you know A is the first alphabet, right? Altogether, first alphabet is A. So amobarbital inhibits electron transport between complex 1 and Q. Okay, amobarbital starts with A. It inhibits electron transport between complex 1 and Q. TTFA starts with T. T stands for 2. Right? T stands for 2. So TTFA inhibits electron transport between complex 2 and Q. 2,4-dinitrophenol is an uncoupler. Okay, 2,4-dinitrophenol is an uncoupler. So what are the uncouplers that you know? 2,4-dinitrophenol, valinomycin, nalinomycin and nigericin. Okay, 2,4-dinitrophenol, valinomycin, nalinomycin, nigericin, all these are uncouplers. Do not include oligomycin here. Please, all students make a mistake here. Do not include oligomycin as an uncoupler. Oligomycin inhibits FO component of ATP synthase complex. Oligomycin inhibits what? FO. It's called as FO to denote that's inhibited by oligomycin. Okay, so that's about inhibitors of electron transport chain. Again, a Jan 2023 MCQ. Try to answer this. Which of the following enzymes is found to be deficient in von Guericke's disease? What is the right answer? Von Guericke's disease is type 1 glycogen storage disorder, right? Type 1 glycogen storage disorder caused by the defect of glucose 6-phosphatase enzyme. Okay, so what is the right answer here? It is choice A, glucose 6-phosphatase. And what have I told you about glucose 6-phosphatase? This is an enzyme of gluconeogenesis. Didn't I tell you? Glucose 6-phosphatase, the last enzyme of gluconeogenesis, is present in endoplasmic reticulum. And that is why microsomal enzyme marker is glucose 6-phosphatase. So glucose 6-phosphatase is an enzyme of both gluconeogenesis and glycogenolysis. And in von Guericke's disease, when glucose 6-phosphatase is defective, both glycogenolysis and gluconeogenesis cannot increase blood glucose. So what will it present us? It will present us hypoglycemia. Please memorize, von Guericke's disease or type 1 glycogen storage disorder will present as hypoglycemia because the enzyme that is defective is glucose 6-phosphatase. Now, debranching enzyme and branching enzyme. Branching enzyme defect is called as what? Yeah, always remember A, B, C, D. A stands for Anderson's disease. A is Anderson's disease, B is branching enzyme. C is Cory's disease, D is debranching enzyme. Okay, so Anderson's disease is caused by the defect of branching enzyme. And when branching enzyme is defective in Anderson's disease, liver will start accumulating an abnormal glycogen without branch point. Branch is the one which provides compactness to glycogen. So without branch point, glycogen is no more compact and glycogen occupies a larger space. So liver cells will start enlarging and that causes hepatomegaly. So what will be the presentation of Anderson's disease? It presents as hepatomegaly and liver cirrhosis. Okay. Debranching enzyme defect is called as Cory's disease. And Cory's disease, when I say debranching enzyme is defect, this is an enzyme of glycogenolysis. And this enzyme is common to both liver glycogenolysis and muscle glycogenolysis. When liver glycogenolysis is defective, it causes hypoglycemia. When muscle glycogenolysis is defective, that causes exercise intolerance. Okay, that causes exercise intolerance. So tell me, what will be the presentation of Cory's disease? Cory's disease presents with both hypoglycemia and exercise intolerance. Okay, myophosphorylase. M for M. Myophosphorylase deficiency causes McArdle's disease. Okay, and when muscle glycogenolysis is defective, that causes exercise intolerance. Okay, so that's about all these glycogen storage disorders. So whenever you're asked about glycogen storage disorders, there are 3 facts that you need to know. Which type is it? What is its name? Which enzyme is defective? Yeah, which type? What is its name? Which enzyme is defective? Once you know these 3 facts, you will be able to find out the clinical features. Okay, so can we fill up this tabular column to understand those 3 facts which I told you? Yeah, so 7 glycogen storage disorders you will have to learn about. First, about type 1 glycogen storage disorder. What is the name? The name is von Guericke's disease. Which enzyme is defective? Glucose 6-phosphatase. That tells you what will be the manifestation. Both glycogenolysis and gluconeogenesis are defective, so it presents as fasting hypoglycemia. Okay. So what is type 2 glycogen storage disorder? Type 2 is otherwise called as Pompey's disease. And Pompey's disease is caused by the defect of acid maltase or alpha glucosidase. So whenever you learn about alpha glucosidase, do not forget to recollect the fact about beta glucosidase defect. Beta glucosidase defect causes Gaucher's disease, and alpha glucosidase defect causes Pompey's disease. And which is the pump of your body? Heart. So in Pompey's disease, heart gets affected. So it presents as cardiomegaly and cardiomyopathy. They also present with hypotonia. So one of the causes of floppy baby is Pompey's disease, caused by the defect of acid maltase or alpha glucosidase. Type 3, which is the third alphabet. Third alphabet is C. So type 3 is Cory's disease, caused by the defect of D-branching enzyme. As I told you, please remember C should be followed by D. D is D-branching enzyme. And this is an enzyme which is involved in both liver and muscle glycogenolysis. Liver glycogenolysis defect causes hypoglycemia. Muscle glycogenolysis defect causes exercise intolerance. Type 4, we are done with C and D. Now it is A and B. Type 4 is Anderson's disease. B, branching enzyme defect. When there is a defect of branching enzyme, an abnormal glycogen without branch point accumulates in liver. That causes hepatomegaly and cirrhosis. Type 5, Roman letter 5 looks like V. You invert V, write it twice. That is M. So type 5 is M, McArdle's disease. M for M, McArdle's disease is characterized by or caused by the defect of muscle phosphorylase. So when muscle phosphorylase or muscle glycogenolysis is defective, that causes exercise intolerance. Okay, so that's about McArdle's disease. Also remember, if the question says second wind phenomenon, second wind phenomenon is a feature of McArdle's disease. Type 6 is Her's disease. H for H, hepatic phosphorylase defect. And when liver phosphorylase is defective, liver glycogenolysis is defective, that causes hypoglycemia. Okay, type 7 is Tarrow's disease. 7 is Tarrow's disease, caused by the defect of phosphofructokinase 1, the rate limiting enzyme of glycolysis. When glycolysis is defective, RBCs get affected, because for RBCs glycolysis is indispensable. When RBCs get affected, it will present as hemolytic anemia. So that's all about glycogen storage disorders. Type 1 presents as hypoglycemia. Type 2 Pompey's presents as cardiomegaly, cardiomyopathy and hypotonia. Type 3 Cory's disease, hypoglycemia and exercise intolerance. Type 4 Anderson's presents as hepatomegaly, liver cirrhosis. Type 5 McArdle's will present as exercise intolerance and with second wind phenomenon. Type 6 Her's will present as hypoglycemia. Type 7 Tarrow's disease, phosphofructokinase 1 deficiency. RBCs get affected, so it presents as hemolytic anemia. Okay, so that's a summary of all the glycogen storage disorders. Didn't I tell you about this question already? Collagen maturation or collagen cross-linkage formation is dependent on vitamin C and copper. Why vitamin C? Vitamin C is necessary for prolyl hydroxylase and lysyl hydroxylase. Why copper? Copper is necessary for lysyl oxidase. All these enzymes are involved in post-translational modification of collagen, which is involved in collagen cross-linkage formation. And that is why vitamin C deficiency or scurvy will present with collagen defect, and that is why they present with bleeding gums. Subendothelial connective tissue is weaker, blood vessels are weaker, and that causes bleeding gums. Okay, so it's vitamin C and copper. Deficiency causing tingling sensation. It is another way of asking which vitamin deficiency presents with neuropathy. The moment you hear the term vitamin deficiency and neuropathy, the first answer should be B12. We know that B12 deficiency presents with peripheral neuropathy, peripheral tingling sensation and glove and stalk distribution. So the first answer would be B12. But B12 was not provided among choices. If you don't find B12, you can go for thiamine, because thiamine deficiency causes dry beriberi, which is CNS involvement, and thiamine is necessary for neuronal metabolism. Okay, so answer for this question is thiamine. But as far as neuropathy is concerned, you can first remember B12 followed by thiamine and even B6. Please remember both B6 deficiency and B6 toxicity will present as neuropathy. Okay. So this is an interesting question, a one-liner on immunoglobulins, and using this question I'll help you understand or help you memorize few other one-liners related to all immunoglobulins. The question is, which immunoglobulin is present in serum or plasma at the highest concentration? Answer is IgG. So what are the facts that you need to know about IgG? It is responsible for secondary immune response. If a person or a fetus or an infant is getting exposed to an infection for the first time, the type of immunoglobulin that is produced is IgM. So IgM is responsible for primary immune response. IgG is responsible for secondary immune response. And IgG can cross placenta. So what are the facts that you need to know about IgG? The maximum concentration, the immunoglobulin with the maximum concentration serum is IgG. It's responsible for secondary immune response. It can cross placenta. So in the fetus, if you find IgG against any microorganism, it means the fetus is not exposed to the infection. This immunoglobulin is generated by the mother which has crossed the placenta. Whereas if you find IgM against any of the infections, IgM is a pentamer. This can be asked as which of the following immunoglobulins has got the highest molecular weight. What will be your answer? IgM, which is a pentamer, IgM. And when it's a pentamer, can it cross placenta? It cannot cross placenta. So in the fetus, if you find IgM against any of the infections, it means the fetus is already exposed to the infection. So that's about IgG and IgM, and IgA is responsible for surface immunity. The next MCQ is nitric oxide is formed from which amino acid? So all of you, when you learn about amino acid metabolism, you will have to memorize about all specialized products that you get from every amino acid. Nitric oxide is something which you get from arginine. But also remember, from arginine you don't only get nitric oxide, you also get few other specialized products, starting from creatine. Okay, so as far as creatine is concerned, they can ask you what are the amino acids that are necessary for creatine synthesis. You can remember that using a mnemonic, okay, GAME. What does GAME stand for? Glycine, arginine, methionine. So glycine, arginine and methionine are all necessary for creatine synthesis. And apart from creatine, from arginine you also get ornithine, putrescine and spermidine. I remember this as COPS. Arginine, COPS. So what does COPS stand for? First one is creatine, second it is ornithine, putrescine, spermidine. Okay, so these are polyamines that can be synthesized from arginine. Okay. A very good image based question. A patient presented to the OPD with liver damage. The picture depicts the patient having their eyes examined. Which of the subsequent factors is the cause of this condition? So can you describe the image here? What is that you observe here? Sunflower cataract. And sunflower cataract is a feature of Wilson's disease. And we know Wilson's disease. What did I tell you about Wilson's disease some time back? I said it's caused by ATP7B mutation, wherein this protein is responsible for secreting copper into bile that causes copper toxicity. Right? And it's hepatolenticular degeneration which presents with sunflower cataract. So this is about copper. But at the same time, you should also recollect all the facts that you know about shaped cataracts. So one other shape that you should remember is snowflake cataract, which is observed in juvenile diabetes. Don't you see that it looks like a snowflake? This is a feature of juvenile diabetes caused by sorbitol accumulation. And then have you heard of oil drop cataract? Yeah, oil drop cataract is a feature of galactosemia. So which alcohol is responsible for juvenile diabetes? It is sorbitol. Which alcohol is responsible for galactosemic cataract? It is galactitol. Okay, so answer for this question, sunflower cataract is a feature of copper toxicity. Breastfeeding is contraindicated in which of the following conditions? Obviously, it's contraindicated in galactosemia. Why in galactosemia? Classical galactosemia is caused by the defect of galput deficiency. This can be a one-liner. Classical galactosemia is caused by the deficiency of galactose 1-phosphate uridyl transferase. In this condition, galactose metabolism is affected. In that case, if you breastfeed that child with galactosemia, breast milk will have lactose. Lactose gets digested in the intestine to give galactose and glucose. Galactose enters into the system. We know for sure that in this child, galactose metabolism is affected. So all features will be exaggerated. So breastfeeding is contraindicated in galactosemia caused by the defect of galput or galactose 1-phosphate uridyl transferase. A patient presented to the OPD with complaints of diarrhea. The patient was later diagnosed with dementia and photosensitive dermatitis in sun-exposed areas. Do you know the answer already? Diarrhea, dermatitis, dementia. In just the last 5-year question paper, this question is repeated thrice. Right? Diarrhea, dermatitis, dementia, 3 Ds of pellagra caused by deficiency of niacin. A woman with complaints of pain, tingling sensation, numbness of the foot has history of taking vitamin supplements. After intake of vitamin supplement, patient presenting with pain, tingling sensation and numbness. What did I tell you? B6 deficiency and B6 toxicity will cause neuropathy. When the daily intake of B6 exceeds 1000 milligram, that causes neuropathy. So what is the right answer here? Hypervitaminosis B6. I am excluding beriberi because which of the following is responsible after vitamin supplementation? Okay. Increased B12 does not cause neuropathy. Low B12 causes neuropathy. Vitamin A toxicity does not cause neuropathy. Vitamin A toxicity presents itself as pseudotumor cerebri. What do you mean by pseudotumor cerebri? You find all features of increase in intracranial tension. The child will the person will present with vomiting, headache, increase in intracranial tension. Features would include hypertension, bradycardia. But if you do any imaging study, you will not find any space occupying lesion. And apart from that, they also present with alopecia and exostotic, bony exostosis. So all these are features of vitamin A toxicity. It does not present with neuropathy. So answer here is hypervitaminosis B6. So when the intake is more than 1000 milligram per day, that causes neuropathy. Vitamin A deficiency leads to what? We know the answer, don't we? Beriberi, no. Thiamine deficiency causes beriberi. Pellagra, no. Niacin deficiency. Neuropathy is caused by B12 or thiamine or B6 deficiency. So what are you left with? You are left with xerophthalmia. So vitamin A deficiency leads to the xerophthalmia. Let's now use this opportunity to learn about whose grading of vitamin A deficiency. Yeah, whose grading of ophthalmic manifestations of vitamin A deficiency. We start with XN. That proceeds to X1A, X1B. That is X2, X3A, X3B, XS and XF. So tell me what is XN? Nyctalopia. The first symptom or the first manifestation of vitamin A deficiency would be nyctalopia or night blindness. X1A is conjunctival xerosis. Okay, X1A is conjunctival xerosis. X1B is Bitot spots. X2, corneal xerosis. X3A, corneal ulcer involving less than 1/3 of the cornea. X3B, corneal ulcer involving more than 1/3 of the cornea. XS is corneal scar. XF is xerophthalmic fundus. So tell me about the WHO grading of ocular manifestations of vitamin A deficiency, starting from XN 1A, 1B, 2, 3A, 3B, 4, 5. XN is nyctalopia, 1A is conjunctival xerosis, X1B, B stands for Bitot spots. 2 is corneal xerosis, 3A is corneal ulcer involving less than 1/3 of the cornea, 3B is more than 1/3. XS is corneal scar, XF is xerophthalmic fundus. A bit about biochemical basis of xerophthalmia in vitamin A deficiency. You will be able to understand this if you know the various forms of vitamin A. So what are the various forms of vitamin A? The alcohol form retinol, the aldehyde form retinal, and the acid form retinoic acid. Retinol is the form in which vitamin A is absorbed, transported, and stored. This was asked once in FMGE. In which form is vitamin A stored? Your answer should be retinol, the alcohol form. Retinal, the aldehyde form. Do you see retina here? In retinal, you see retina. It is found in eye. So in eye, we have rhodopsin and conopsin. Rhodopsin until stimulated by light. As long as there is no light, it is levensis retinal in the center, surrounded by opsin. So until stimulated by light, what is vitamin A? Until stimulated by light, what is rhodopsin? Rhodopsin is levensis retinal in the center, surrounded by opsin. Retinoic acid, we have two forms of retinoic acid, all trans retinoic acid and 13-cis retinoic acid. All trans retinoic acid helps in growth and differentiation of epithelium. Whereas 13-cis retinoic acid suppresses keratinization of epithelium. That is why what happens in vitamin A deficiency, there is no suppression of keratinization of epithelium, excessive keratinization happens. Skin keratinization will present as phrenoderma. So this can also be asked as an image-based question. Phrenoderma or follicular hyperkeratosis is a feature of vitamin A deficiency because of excessive keratin debris accumulation. Okay, and excessive keratinization of conjunctiva is the reason for conjunctival xerosis. Keratin debris is the reason for Bitot spots. The same is the reason for keratomalacia and corneal ulcer. So all these because of a deficiency of 13-cis retinoic acid, which is necessary for suppressing keratinization of epithelium. Okay, so that's about vitamin A deficiency. Here the answer is xerophthalmia. Okay, Jan 2023 MCQ again. Cytochrome P450 is associated with what? It is NADPH. Okay, cytochrome P450 is associated with NADPH. So many a times questions are asked about NADPH. Two sets of questions are asked. One is what are the uses, the other one is what are the sources. So what are the sources of NADPH? Most of the oxidative steps happening in your metabolic pathways generate NADH. There are just three sources of NADPH. The first source of NADPH is HMP shunt. Major source of NADPH is HMP shunt. Second source is cytoplasmic isocitrate dehydrogenase. Third source is malic enzyme which converts malate to pyruvate. So what are the three sources of NADPH? Major source is HMP shunt, cytoplasmic isocitrate dehydrogenase, and malic enzyme which converts malate to pyruvate. Now what are the uses of NADPH? It is necessary for reductive biosynthesis of all the lipids, be it fatty acid synthesis or cholesterol synthesis or bile acid synthesis. So all these lipid synthetic pathways will need NADPH. Second use of NADPH is it is necessary for regenerating glutathione, which is an important antioxidant mechanism of RBCs. And that is why tell me what happens when there is a defect of HMP shunt. G6PD deficiency. Please don't get confused between glucose 6 phosphatase deficiency or von Gierke's disease or type 1 glycogen storage disorder which presents as hypoglycemia. and G6PD deficiency, glucose 6 phosphate dehydrogenase deficiency, there is no NADPH, no regeneration of glutathione. So RBCs are susceptible to lysis. Yeah, they present as hemolytic anemia following an exposure to oxidative stress. So the second use of NADPH is regenerating glutathione in RBCs. Third use of NADPH is it is necessary as a coenzyme for ribonucleotide reductase. Okay, ribonucleotide reductase, which is necessary for deoxynucleotide synthesis. The fourth one is the question. It is necessary for cytochrome P450 enzymes. So have you understood all about NADPH? Please remember NADH is different from NADPH. NADH can enter into electron transport chain. Every NADH gives rise to 2.5 ATPs. NADPH cannot enter into electron transport chain. It can never give rise to ATP. But what are the uses of NADPH? Fat synthesis, regeneration of glutathione, ribonucleotide reductase, cytochrome P450 enzymes. What are the sources of NADPH? The most important source of NADPH would be HMP shunt, cytoplasmic isocitrate dehydrogenase, and malic enzyme. Okay. What kind of inhibition does this graph depict? Okay. So whenever you're shown a graph, you're asked to find out what type of inhibition it is. I don't want you to just blindly memorize. If it's a V, it is non-competitive inhibition. Parallel lines and competitive inhibition. Don't do that. Because if you do that in future, when you try to do a research, you will not be able to read any article. Yeah, most of the pharmacological articles will be based on Line-Weaver-Burke plot. So first tell me what is a plot that is shown to you here. It is Line-Weaver-Burke plot, otherwise called as double reciprocal plot. Why am I calling it as double reciprocal plot? Because on the y-axis it is 1 by V, on the x-axis it is 1 by S. On both x and y-axis reciprocals are shown. That's why it's called as double reciprocal plot. So whenever you're shown a Line-Weaver-Burke plot or double reciprocal plot, you should first find out which curve represents uninhibited curve, which curve represents in the presence of inhibition. Have you identified that in the image? They have clearly marked that this line is uninhibited, this is inhibited. After identifying these two lines, find out what happens to Km, what happens to Vmax in the presence of those inhibitors. Okay, in the presence of inhibitor, what has happened to 1 by Vmax? 1 by Vmax is increased, which means Vmax is low. Okay, but what has happened to Km? Irrespective of whether there is an inhibitor or not, Km remains the same. So if Vmax is low and Km is normal, yeah, if Vmax is low and Km is normal, N stands for non, K stands for competitive inhibition. Normal Km is a feature of what? Non-competitive inhibition. So answer for this question is choice C. But you have to know about every type of inhibition. That you will be able to understand if you fill up this tabular column along with me. Okay, so there are 4 types of inhibition about which we have to learn. The first one is competitive inhibition. Second one is uncompetitive inhibition. Third one is mixed inhibition. Fourth one is non-competitive inhibition. Okay, these are the 4 types. Now what happens to Km? What happens to Vmax in competitive inhibition? In competitive inhibition, all that happens is there is a competition between the substrate and the inhibitor to go and bind to the enzyme. It is just a competition between the substrate and the inhibitor to go and bind to the enzyme. In that case, tell me what will happen when you increase a substrate concentration. What will win the competition? Substrate will win the competition, overcoming the inhibitor. So increasing the substrate concentration will overcome competitive inhibition. If you can overcome competitive inhibition, what happens to Vmax? Vmax remains normal. But to reach that Vmax, you have to increase the substrate concentration. So Km is increased. Because what is Km? Km is the substrate concentration at half maximal velocity. Do you understand this? Km is the substrate concentration at half maximal velocity. So in the presence of a competitive inhibitor, you can overcome the inhibition. So the final Vmax is achieved. But to reach that Pmax, you have to increase the substrate concentration. So Km is increased. What happens in uncompetitive inhibition? You cannot overcome this inhibition. If you cannot overcome this inhibition, then Vmax will be less. And uncompetitive inhibition, it's always parallel lines. Yeah, parallel shift. So Vmax is low, Km is also low. Both the values get altered in the same direction. In uncompetitive inhibition, Vmax is low, Km is also low. Mixed inhibition, both the values get altered in the wrong direction. For an enzyme to be an effective enzyme, its Vmax has to be high, Km has to be low. But in the presence of a mixed inhibitor, Vmax is low and Km is high. If both the values get altered in the wrong direction, that is mixed inhibition. Finally, non-competitive inhibition. How did I ask you to remember? The name tells you. In the presence of a non-competitive inhibitor, what is normal? Km is normal. What happens to Vmax? Vmax is reduced. Okay. So, can we fill up this tabular column again? Yeah, competitive inhibition, you can overcome the inhibition. So, Vmax is normal, but Km is high. Uncompetitive parallel lines, both Vmax and Km are low. Mixed inhibition, both the values get altered in the wrong direction. So, Km is high and Vmax is low. Non-competitive inhibition, normal Km and Vmax is low. That's all about types of inhibition, which you'll be able to see on the Lineweaver-Burke plot. So always when you see the plot, see what is along y-axis, what is along x-axis. Along y-axis it is 1 by V, along x-axis it is 1 by S. Then find out which is the uninhibited line and which is the inhibited line. Find out what happens in the presence of the inhibitor to Vmax and Km. Then find out what kind of an inhibition it is. Okay. So this is the last MCQ for this session. Which of the following is cardioprotective? It is omega-3 fatty acids. Yeah, omega-3 fatty acid includes cervonic acid. So what is cervonic acid? It is docosahexaenoic acid. Ecosa means 20, docosa means 22. So docosahexaenoic acid has got 22 carbon atoms with 6 double bonds. And it's of omega-3 type, and that is cardioprotective. Yeah, and this is what is available in cod liver oil or in all fatty acid, essential fatty acid capsules and tablets. So omega-3 fatty acids are cardioprotective. Example is cervonic acid, which is docosahexaenoic acid. Okay, thank you, and my best wishes to all of you. Please learn every topic conceptually. And whenever you work out previous year MCQs, learn related facts and concepts and keep revising every fact that you learn and every concept that you have understood. Yeah, you will definitely become successful. Best wishes and thank you.